Very good evening, everyone. I'm Dr. Divya Gupta, the original guru of Periodontics at DBMCI. And today we are live to discuss the previous year questions. So now only 2 months are left for INI-CET, and I hope all of you are. Very good evening, everyone. I'm Dr. Just hold on. Yeah. So I hope now all of you are in the revision mode. And so today is like this session, the rewind session by DBMCI is an attempt so that in the last minute, 2 months before INI, we can give you the most frequently asked topics. We can revise the most frequently asked topics in INI-CET. So what I have done is I have taken questions from like last 3 years paper, and then I'll tell you the topics from which those questions have come, and also the past questions from last 5 to 6 years papers. So till 23, there will be the first question will be from 23, 24, 25 INI-CET papers. And after that, the questions which I'll be discussing quickly from those same topics only, the questions which have come previously, like from 2016, 17, 18 till 2022. Okay, so with that said, let us start the discussion, guys. And I would love that first I'll read out the questions and the options. We'll discuss the explanation, but I would love that if you all can give me the answer in the comment section on YouTube itself. Yeah. Hi, everyone. Masoom Boy, Shaniba. Good evening, Radhe Krishna. So let us start the discussion, okay? Without wasting much time. Please do answer in the comment section as quickly as possible. So the first question is from the last year, May 2025 question only. Guys, one more thing I want to add is since last 1 or 2 papers, the trend has changed. They have started asking more application based questions. Okay. So the topics are repeat only, but your concepts should be very clear. Okay. There are some topics, some conceptual topics in periodontics, such as number one topic is classification. Then there is post modulation and inflammation, which is there in perio. Those are some topics where concepts are required, and those topics we have discussed conceptually only in our live classes as well as our recorded sessions. Okay. So I hope those questions will be able to solve, and those questions I'll tell you also, okay, how to solve. Okay. So let us start the discussion. The first question is a patient with clinical attachment loss of less than 2 mm. A patient with clinical attachment loss of less than 2 mm over previous 5 years, over previous 5 years, and smokes more than 10 cigarettes per day, more than 10 cigarettes per day, what will be the stage of periodontitis? So, guys, this is a question from 2017 classification. You have to memorize. This is very, very, very important. The staging and the grading of periodontitis is very important. Last year, 2 questions were asked in May INI. So, it is not difficult at all to remember. I'll tell you how to remember. And what you can do is you can take a printout or you can write it down somewhere, and every day just look at it and you will know how to answer such questions. These look difficult, but they are not at all difficult once you understand the concept of such questions. Okay. So the first question, so the options are grade A, B, C, and D. Okay. So let us see how the periodontitis is classified into. Grade D is not there. If anyone of you can answer the answer to this question in the comment section, it would be great. Otherwise, after the discussion of the explanation, I'll tell you the answer. So, how we classify periodontitis into different grades? Periodontitis is classified as grade A, B, and C. Grade A is slow rate of progression, grade B is moderate rate of progression, and grade C is rapid rate of progression. Now, grades are used as an indicator of rate of progression of disease. Now, whatever I am telling you is written here very clearly. It is used as indicator. It is used as an indicator for, indicator for rate of progression of periodontal disease. The primary criteria here, the primary criteria are direct evidence and indirect evidence. What is the direct evidence? If the patient has come to me, suppose for a follow-up after 5 years, and I have taken the radiographs every year, I can monitor the amount of bone loss the patient is undergoing, right? So if indirect evidence for longitudinal data, if there is no loss over 5 years, the patient is slow rate of progression of periodontitis. If less than 2 mm of bone loss is there in 5 years, it is moderate, and in grade C, there will be more than 2 millimeter of bone loss over 5 years. In indirect evidence, you can either calculate the amount of bone loss or the percentage of bone loss from the radiograph or the case phenotype, means whether there are more amount of deposits present, the amount of destruction, is it is it correlated with the amount of deposits or not? That you have to see based on your clinical examination. So the percentage of bone loss, if it is less than 0.25, it is slow rate of progression. In moderate, it is 0.25 to 1, and in rapid, it is more than 1. Okay. In case phenotype, heavy deposits are present with low levels of destruction, means the patient will have large amount of calculus, but the amount of bone loss will not be that much. In grade B, the destruction commensurates with the amount of deposits, means the patient has high amount of deposits, plus he or she has that much amount of bone loss as well. And in rapid rate, rapid is similar to that of aggressive periodontitis. Now, the term aggressive periodontitis is not used. The term which is used is rapid rate of progression. So here the destruction, the amount of bone loss is much more than the amount of disease present or the amount of calculus present, and it is suggestive of rapid progression or early onset disease, similar to that of aggressive periodontitis. Okay. Once you have decided the primary criteria, okay, and if in the question the primary criteria is not given, all the cases you have to keep as grade B only. In the question, they will give you one thing, either primary criteria or grade modifiers. If grade modifiers are given, okay, if the primary criteria is given plus grade modifiers are given, what you will do? You will give importance to grade modifiers. Okay, what are grade modifiers? These are risk factors such as smoking and diabetes. If a patient is non-smoker, he is in grade A. Okay, if a patient is a smoker but less than 10 cigarettes per day, grade B. In grade C, smoker more than or equal to 10 cigarettes per day. Diabetes means normal glycemic HbA1c less than 7 in patients with grade B periodontitis, and in grade C more than HbA1c will be more than 7%. Okay. So this is how you have to look at the grades of periodontitis. Now staging, how you will, so this is very important. Okay, staging and grading. Staging is the initial stage should be determined using clinical attachment laws to decide what stage is periodontitis, stage 1, 2, 3, and 4. Okay. How much severe is the periodontal disease will be decided based upon the amount of clinical attachment loss, radiographic bone loss, tooth loss, whether. So accordingly, we will classify the patients as stage 1, 2, 3, and 4. Okay. Complexity factors decide how much complex the disease is. Okay. So if we'll take these criteria like maximum probing depth less than equal to 4 mm, horizontal bone loss is present, maximum probing less than equal to 5 mm. All these things you have to memorize, guys, because in the questions, they'll give you these things only. In the questions, they will give you these things. You have to memorize it. You don't have any other option. So everything which is written, and this is only important, you don't have to memorize whole of 2017 classification because it is very big. It is an article. If you want, I'll share it in the group, Telegram group. but it is a very big article. It is very difficult for you to memorize it completely. It is difficult for me as well. But these two things are very important, the staging and grading, and the questions are asked frequently now. Since last 1 year, they have started asking questions from classification, this 2017 classification. Okay, so you have to memorize it. So take a screenshot, stick it somewhere and read it daily. You will memorize it. The answer, sorry, the answer to this question is grade C. The answer to this question is grade C. So all of you who answered grade C, good. Now, similar to this question, another question was asked in the same year in the same paper. If the lower mandibular molar shows recession with interradicular through and through bone defect, with intraradicular, through and through bone defect. This is through and through is Glickman's stage 4, right? Glickman's grade 4. With 5 clinical attachment loss and vertical bone loss, what will be the stage of periodontitis? Option is option number A, stage 1, 2, 3, and 4. What is the answer to this question, guys? If any one of you can tell me this. See here, we will look at the stage 1, 2, 3, and 4. Then, here they have shown that there is through and through bone loss. There is recession as well. There is recession as well, means there is recession and we can see the bone defect through and through. So let us look at the complexity factors here. The clinical attachment loss also they have given. This 5 of clinical attachment loss. 5 clinical attachment loss, 5 and equal to clinical attachment loss is stage 3. So let us look at the complexity factors of stage 3. Probing depth more than equal to 6 vertical bone loss is there, more than equal to 3 furcation involvement class 2 or class 3, and moderate ridge defect, right? Here, in addition to stage 3, there is need for complex rehabilitation, masticatory dysfunction, occlusal trauma is there, bite collapse is there, less than 20 remaining teeth. But here, guys, what is the... See, here they have not mentioned the furcation involvement class 2 and class 3 only they have given. But here in stage 4, they have not mentioned class 4. Okay. And the other complexity factors which they have mentioned in the question, it has not been asked. So here the answer will be, the answer for this question will be what? It will not be stage 4, guys. It will be stage 3 only. It will be stage 3. Look here. This recession plus intraradicular through and through bone defect. I hope you remember that in Glickman's classification. In grade 3 also there is through and through defect. But why the probe cannot pass through and through the bone, interradicular defect? Because the soft tissue is attached to the dome of the roots, right? The soft tissue is attached to the dome of the roots. So the probe cannot be inserted, but there is through and through defect, bony defect present. There is recession also. So here in this classification, though they have not given class 3 and class 4 as separately, but that class 2, class 3 and class 4 furcation involvement will be considered in stage 3 only, guys. Okay, it will be considered in stage 3 only. So the answer here will be stage 3. The answer here will be stage 3. Okay. Now the next question. Sorry. Okay. The next question is, this is also once again a very important topic, gingiva in disease. From gingiva in disease, everything. Gingivitis, periodontitis means chronic periodontitis. You will get case-based questions from chronic periodontitis. Aggressive periodontitis, the clinical features of aggressive periodontitis, that too, particularly localized aggressive periodontitis is very important. Then you should know about the types of periodontal pockets which are there, diagrammatic questions, IBQ image-based questions come from those topics as well. Okay. So these are the most commonly asked topics. From gingiva in disease, you should be very thorough. See, these all topics are very much interlinked. Okay. And we have studied that in that way only so that we can easily memorize them. So the question number 2 is, most collagen destruction happens in which stage of gingivitis? So there are 3 stages of gingivitis, And the fourth stage is advanced stage, which is considered in periodontitis. So let us see what are the stages of periodontitis, stage 1, 2, 3, and 4. So the questions which can be asked are most commonly the predominant cell, immune cell, which is present in which type of stage. Okay, then you should be very thorough with this table as well. You should be very thorough with this table as well. Here, you should know that stage 1 happens in 2 to 4 days, then 4 to 7 days, 14 to, I'll not discuss everything in detail because we have a very limited time of 1 hour. But yes, this is important, guys, right? This is like a revision for you. You see this and it get refresh in your minds. So this is just for your revision, like short briefing about, important topics. Everything in detail we cannot tell you today in this 1 hour. Okay. But seeing this, it will be like, okay, yes, we have studied this and it is there. And we know this. This topic, we are very thorough. We don't need to read it again for INI. But yes, here you will learn something new. Like, I think for most of you, classification of periodontal diseases, the recent one would be difficult. So just before going to the exam, be thorough with the classification, at least the staging and grading, because yes, they have started asking questions from the topic. Okay. So clinical findings, you should be very thorough. In this, in stage 4, the loss of connective tissue, and attachment and alveolar bone occurs in stage 4, which is the advanced disease. So the answer to this question is stage 4. Okay. Now the next question. Probing on labial aspect of tooth was painful. What can be the reason? So this is an application based question, right? We don't directly say, okay, like we don't directly teach in the class, okay, probing will be painful. Why? This is an application based question. Why it will be painful? Option: abscess is there. Option number B is ulceration of the inner wall of the pocket. Option number C is hyperemia. And option number D is gingival fiber breakdown. Whenever there is ulceration, ulcers are painful, right? So ulceration of the periodontal pocket wall will lead to pain during probing. So the answer to this question is ulceration. The answer to this question is ulceration of inner wall of the pocket. Yes, it is B. Okay. Now the next question. Another frequently asked questions from the topic periodontal instruments. From periodontal instruments, just write it down what all things are important. You should know about explorers. These are the explorers. Okay. Then you should know about the types of probes. Mostly the most commonly asked probes are neighbors probe, UNC 15 probe, and WHO probe. Right? CPIT and E and CPIT and C probes. These are the probes. WHO and CPIT and probe are the same probes. So these are the probes most frequently asked. Apart from that, curates are asked. Differences between Gracie curates and universal curates, you should know. Then you should, in image-based questions, they can ask you about the supragingival scalars, the subgingival scalars, such as Poe scalars, the chisel scalars, the file scalars. These are the image-based questions that they can ask. Then you should be very thorough with the ultrasonics, the magnetostrictive, the movements of magnetostrictive, the sonic scalars, the piezoelectric scalars, what are the different types of movement, what is the frequency with which they are rotating. All these things from the chapter of types of instruments is very important. Apart from those, you should know the instruments for gingivectomy. You should know the instruments for bone resection. You should know the steps of bone resections. Okay, so in instruments, so steps of bone resection is completely different topic. But yes, you should know the instruments for surgery. You should know about the types of sutures. These are very important from the instruments chapter. Okay. So whatever I am telling you right now, just write it down. Make a note of everything. Okay. So here, this is also one of the repeat questions. Most of you will answer this correctly, guys. Remember, in exam last year in May INI, there were 20 questions from Perio. Most of the questions were application based. I would say 16 questions were from the repeat topics, but 4 questions were out of nowhere. So guys, see, don't, if out of 20 questions, you are getting correct the 16 topics, 16 questions of the repeated topics, it's good enough, right? 4 questions which you are not able to answer, have that much confidence that other people also, the other students are also preparing the same in the same way like you are preparing. Okay. So for those students as well, those questions will be difficult to answer. But you cannot allow yourself to be wrong in any of the repeated topics, in any of the repeated questions. So just make it a point that all the repeated topics, I'll be very thorough. Then go to the topics which are less common, right? To the uncommon topics, you can go. Okay. So here in this question, identify the instrument. This is an explorer. This is 1723. This is Orban type explorer. Okay, Orban type, and this is Shepherd's hook. Shepherd's hook type of explorer. It is, the number is 1723. Okay. Similarly, this is the probe I have shown. This is also easy. The identify the probe which is shown here. Now you can see here there is marking on every and the marking is still 15 So it is option number A is CPITN probe. Option number B is UNC 15 probe. Option number C is WHO probe, and option number D is Williams probe. CPITN probe, WHO probe are the same probes, and it has a ball end of 0.5 millimeter in diameter. The markings are also 8.5 and 11.5. It is not till 15 Okay, so the answer here is UNC 15 probe. It is UNC 15 probe, right? Similarly, the other question which can be asked here is based upon the motion of scalar tip, the image given below. This is also more frequently asked question. So these, see, the first question is either like it is from the recent paper May 25 or November 24. The other questions which I am telling you are from like 2022, 21, 20. Okay, guys? Yes. So the answer based upon the motion of the scalar tip, based upon the motion of the scalar tip, in the image given below, identify the type of scalar. Options are option number A, magnet. So here you can see that it is a circular motion, right? It is a circular motion. So options are magnetostrictive, piezoelectric, sonic, and supersonic. There is nothing like supersonic. So magnetostrictive will have an electrical motion. Piezoelectric will have a linear motion, and the sonic will have a circular motion. This is a circular motion, right? This is circular motion. So the answer to this question is sonic. It is C. Okay, I hope most of you are able to answer these questions, guys. I can see B, B, B. Any doubts, any queries till now? The answer to 3.3 is C. Okay, now the next question. So this is from May 2025 only. This question at first looks like kya puch liya? We don't know. We have no idea. We have no clue what they have asked. But if you just apply a little bit of logic, and guys, just like what happens is when we are anxious, when we are fearful of something, our mind blocks. There is a blockage in our mind. So before going to the exam, just meditate a little bit for 5 to 10 minutes. Be confident about your preparation. You will be anxious, and when I was at your age, I was also anxious, and in that anxiousness, I made few silly mistakes. So it is like you can say it as just advice from a senior kid. Try to be confident. Try to be no over. You should not be very overconfident, but yes, try to be confident that you have studied, you have worked hard for 1 and 2 years, right? And that will be fruitful. God is there with you, and your hard work will be rewarded, right? We all know how much we have prepared, and accordingly, the fruits will be given to us. Huh? Okay, so now the dental bud polyclinic only scoop out from scalar. I didn't understand your question. Okay, so let's move to the next question. The next question is single nucleotide polymorphism. Single nucleotide polymorphism of the question of interleukin 1 alpha and interleukin 1 beta. What is true? What is true regarding the following? Okay, whether this polymorphism is a risk factor. So this is an application. It is not a direct question, right? They have just given a gene mutation and they have asked you whether this is a risk factor or a risk determinant or a risk predictor or a risk indicator. So remember, guys, we have studied this, right? We have studied this table. This is important. We know this. No, this is important for exams. This is from the topic periodontal treatment planning. Subtopic is risk factor. Periodontal treatment planning. What all topics are important? Risk factors are important. Merins recoil classification is important. Then you should know about the stages of treatment planning. Okay, emergency phases of treatment planning, emergency phase, heterotopic phase, then surgical phase, then prosthetic phase. Okay, in between there is maintenance phase. So you should be very thorough of those phases. These three things are very important. Then prognosis, classification of prognosis given by McGuire and Nunn, that is very important for you to remember. So whatever I'm telling you, just keep writing. You should be very thorough with this. And here, see, risk determinants, the factors these are the risk factors. What are the risk determinants? These are the risk factors which cannot be modified, right? Yes, these are the risk factors which cannot be modified. These are the genetic factors. So these factors will come under risk determinant. These will come under risk determinant. Okay. Now the next question. This is another important topic, gingiva disease, and the subtopic here is the effect of smoking on periodontium or periodontal tissues. Such questions are frequently asked in INI. They will give you multiple options which are correct, and you have to choose what are the correct options, right? So here, periodontal effects of smoking. The first option is GCF. What happens? What are the periodontal effects of smoking? Number one is GCF flow decreases initially and then it increases. Means here they have just given decreases initially, but you must remember that initially GCF flow decreases, then it increases. Option number two is sublingual increase in temperature. Option number three is increase in fibrinogen. Option number four is decrease in fibrinogen. And option number five is decrease in number of yellow complex bacteria. Okay, so let us look at the options one by one. Option number one is GCF flow decreases initially. Yes, this is true. Second option is sublingually there is increase in the temperature. No, there is no increase. Sublingually there is no increase in the temperature. Then there is now out of these two, increase in fibrinogen and decrease in fibrinogen, you should know that one will be correct. One will be correct because either they have given two opposite statements. So obviously out of these two, one will be definitely correct. So increase in fibrinogen or decrease in fibrinogen. So what happens in smoking is, in smoking there is increase in inflammation and fibrinogen increases in during inflammation. So in smokers, there is increase in fibrinogen in the serum. Then in option number five, decrease in number of yellow complex bacteria. No, all the periodontal pathogens in smokers increases. Why? What happens during smoking is when we are smoking an anaerobic environment, there is more amount of carbon dioxide in the oral cavity. So more amount of anaerobic environment is created into the oral cavity, which favors the growth of periodontal pathogens. Okay, so the amount of red complex, specifically the amount of red complex bacteria increases and all other complexes also increases in smokers. So the answer to this question is option number C, which is 1 and 3. Yes, it is option number C, which is 1 and 3. So here, this is the table. You can take a screenshot of this. Due to time limitation, I'm not going to read out everything. Just take a screenshot of it. Okay. And you have to It is application based. You don't have to ratify everything, right? You will read it, you will understand the concept, and it is easier for you to remember. Okay. Now the next question, from smoking only. Which of which of the following is noticed in smokers? This is similar to the above question only. Decrease in temperature in the pocket, decrease time in recovery from anesthesia, then increase microbes in shallow periodontal base, pocket base, increase in GCF. The answer to this question is option number B, which is A, C, and D. A, C, and D are correct. Okay. Now the next question is, plateau-like bone margins are seen in which type of bone defect? Plateau-like bone margins. So this again is a very, very important topic, which is bone loss and thought patterns of bone destruction. In this, one more topic I would add is osseous resective surgeries, the stages of osseous resective surgeries, stages of osseous resective surgery are very important. You have to remember that them in order. Okay. So plateau-like bony margins are what? Option number A, craters. Option number. In case of TFO, it remains unchanged. Aditi, your question, what happens? So Aditi is asking, what happens to GCF in case of TFO? It remains unchanged. It is not changing. Okay, Aditi? So here, plateau-like bone margins are seen in option number B, ledges. It is ledges, right? It is ledges. Now, similar to these image-based questions, IBQs are also asked from bone loss patterns. So you must be thorough that what is crater, what is negative architecture, what is positive architecture, what is flat architecture, what is a three-wall defect, two-wall, one-wall, all the vertical defects you should be very thorough with. These all things are given there in our notes, everywhere. Okay, these are very common topics, guys. So identify the given pathology in the image. Here you can see that the radicular bone is at a more, the radicular bone is at a more coronal level, and the interdental bone is at a more apical level. So it is what? It is a reverse architecture. Sorry, the answer to this question is reverse architecture. It cannot be a crater. Why? In crater, there is interproximal bone loss, but the buccal plate and the lingual plate are intact. Means these cortical plates, they are intact. Okay, these cortical plates, if we see it from the buccal side, it is intact. The defect is the crater like this scooped out, or the crater like defect is present interproximally. Okay, understood? Now, the next question. Okay, Sada is asking, ma'am, in TFO radiographically, is there any bone loss seen or just whitening of PDL? No, there will be bone loss. Initially, there will be fuzziness, then there will be vertical bone loss seen in TFO, guys. Yes. Okay, Pariniti Pathak, hey, Sada, in TFO reverse architecture is yes. Okay, chalo. Now the next question. Okay, sorry. This is also an image-based question frequently asked. Last time also it was asked. So just have a look at it, that what is the image showing, whether it is a fenestration and dehiscence, ledges, sinus fistula, or shelf life conformation. It is fenestration and dehiscence. Fenestration is like a hole. The marginal bone is intact, and dehiscence means the marginal bone is lost. Okay. Now the next question. Internal bevel incision. This was also asked in May 2024. I have a sore throat today, so I have to take water continuously. So question number 7 is, internal bevel incision as marked with number 2 in the image below will raise this. Will raise what? Option number A is modified treatment flap. Option number B is undisplaced flap. Option number C is apically displaced flap. And option number D is coronally displaced flap. So this is an image-based question. Another very important topic, which is periodontal surgery. Periodontal surgery From periodontal surgery, the topics which are important are you should know about the different types of periodontal flaps which are there, periodontal flap techniques, most commonly modified treatment technique, a Kirkland's flap, and a papillary preservation flap. Then you should know about the three different types of horizontal incisions, the vertical incision, the cutback incision. Then you should know about the types of sutures. You should be thorough with mucogingival surgeries. In mucogingival surgeries, the classification is very important for recession. Okay, both the classifications, the Miller's classification and Cairo's classification, both are very important. Then you should know about the techniques. From technique point of view, the bilaminar technique is important. The subepithelial connective tissue graft technique is important. Free gingival grafting technique is important. Yes, in gingivectomy, the instruments I told you is very important. You should know about the four type of horizontal incisions are there: external, internal, bevel, interdental, and clavicular incisions are there, right? Then you should be thorough with the different types of sutures, suture materials. You have to remember the classification of suture materials, which is there: absorbable, non-absorbable sutures. Okay, that you should be thorough with. So here, option number 2, the image, what is this 2 showing? Options are modified treatment flap. Option number C is B. So the answer here, guys, is B, undisplaced flap. Why undisplaced flap? See, this is an image from Carranza. This 1 and 3 show the incision of modified treatment flap and apically displaced. In modified treatment flap and apically displaced flap, what we are doing is we are not removing the whole of infected pocket. What we are removing is just the pocket lining which is here. Okay, that's the pocket lining which is here. But in undisplaced flap, right? In undisplaced flap, we are removing whole of the pocket, removing whole of pocket, whole of pocket. What we do in undisplaced flap is we'll measure the periodontal pocket depth from here. Okay, we'll measure the periodontal pocket depth. We'll mark the point here. We will begin our incision from here and remove. Take it more apical to the alveolar crest and remove whole of the pocket, infected pocket that will be removed. We'll suture this flap again here. We will suture after cutting. We will suture this flap here. So here you will see some amount of recession. So this technique is just used theoretically. Clinically or practically, we are not using this technique. But yes, they have given the points. We have discussed the points. So that points you have to remember. It can be asked. It was asked recently only in May 2024. Okay. So it is undisplaced flap. Now this is the next question. Practical question. For a 25-year-old female, crown lengthening procedure is to be done in. So here, yes, questions from crown lengthening also. This is what I am saying. Since last 2 years, 2 to 3 years, the number of application-based questions have increased in INI specifically. I'm not talking about NEET, but yes, INI. So if you have your concepts clear, you will be able to answer the questions nicely. So here, a 25-year-old female crown lengthening procedure is to be done on the maxillary second premolar tooth. On clinical examination, buccally, the tooth is at the level of gingiva. Buccally, the tooth is at the level of gingiva. So first what we'll do, blank paper is given to us, right? So we'll draw a tooth, okay, a broken tooth, and the depth of that tooth, the level of that tooth is at the level of gingiva. This is the gingiva. I'll draw the gingiva in red. So it is at the level of gingiva. Now they are saying there is 3 mm of attached gingiva. There is 3 mm of attached gingiva and 2 mm is transgingival probing depth. Transgingival probing depth means what? Transgingival probing depth means if I'm taking my probe and penetrating up till the alveolar crest, that is the transgingival probing. This can be done only after giving anesthesia, local anesthesia, and this is 2 mm. We have to consider during crown lengthening, we have to consider biologic width of 2 mm. And in crown lengthening, minimum height which I should get is 2 mm. So if I have to get a 2 mm tooth here, this transgingival probing depth is 2 mm. If I cut at the level of the bone, right? If I cut at the level of the bone, I will interfere the biologic width, right? I'll interfere the biologic width and there will be more bone loss. So what I have to do? I have to do osseous reduction here. I'll have to do osseous reduction here. 2 mm to 3 mm bone should be reduced. Then I have to take whole of this flap below because there is sufficient width of attached gingiva present. So it is apically displaced flap. The answer here is apically displaced flap with osseous reduction. Okay, the answer is apically displaced flap with osseous reduction. Okay, now the next question. Which of the following is used in modified Wiedemann flap? So see, everywhere they can ask you from any of these topics which we are discussing, they can ask you multiple choice questions, right? Like multiple answers are correct. Such type of questions can be asked. So which of the following is used in modified Wiedemann flap? Options are option number A, periosteal elevator. Option number B is Kirkland knife. Option number C is Orban's knife. And option number D is area specific curate. So the answer here is yes. In modified Wiedemann flap, periosteal elevator is used. In option number B, Kirkland knife is used. Option number C, that is Orban's knife, is also used. But area specific curate, it's not necessary that we only use area specific curate. There are other curates which we can use. So the answer here will be A, B, and C. The answer here will be A, B, and C. Okay. Okay. Sada is asking, ma'am, can you please explain this question once again? Sada, which question you are asking? Please write it down. Then this is also a repeat question. Bilaminar technique of gingival recession means. This is again a repeat question from the topic of mucogingival surgeries. Here option number A is 2 adjacent grafts taken to cover the exposed root surface. Option number B is 1 free gingival graft and 1 coronally displaced graft. Option number C is 1 connective tissue graft and 1 apically displaced flap. And option number D is 1 connective tissue graft and 1 pedicle graft. Arshad is saying, so Arshad, you just tell me which question you are not able to understand. We'll discuss that, okay? Sada, sixth question. This crown lengthening one you are asking me, I'll explain it to you at the end of the session. Don't worry. Again. Okay. Okay. So the next question. Okay. So here bilaminar means 2 lamellas, right? 2 lamellas. 2 layers are there, which we are bilaminar means there are 2 layers of grafts which are used for gingival recession. So in bilaminar technique, we are either using a pedicle graft, a laterally displaced graft, or a coronally displaced graft can be used along with a connective tissue graft. So the answer here is option number D. See, option number C, what they are saying. Option number C, they are saying 1 connective tissue graft and 1 apically displaced flap, right? In option number D, they are saying 1 connective tissue graft and 1 pedicle graft. Pedicle grafts can be of 3 types: laterally displaced graft, coronally displaced graft, and apically displaced flap, right? So any of these pedicle grafts can be used in bilaminar technique. Most commonly, laterally displaced and coronally displaced grafts are used. The answer to this question is option number D. Now the next question is again NUG, necrotizing ulcerative gingivitis. This topic, guys, it's like you take NEET, you take INI. This topic, one question will always come. Sometimes there are 2 questions from this topic. So NUG to like it's like neend mein bhi utha ke if anyone is asking you anything, you should know it. Okay, you should know it. So NUG is very important. NUG, anything, any damn question from this topic you should know. So, according to Horning and Cohen classification, stage 3 and stage 4 is suggestive of option number 1, NUP, option number 2, NUG, option number C is NUG and NUP, and option number D is necrotizing stomatitis. So Horning and Cohen classification is divided into stage 1, 2 till 7, and there the classification says in NUG, what is happening? There is punched out crater like necrosis, right, of the gingiva. So this necrosis, when it starts at tip of the interdental papilla, it is stage 1. Then it extends to entire papilla. Then it involves the attached gingiva, entire mucosa. Then it can perforate the alveolar bone and the skin. Accordingly, it is classified as stage 2, 3, 4, 5, 6, and 7. So stage 3 and 4, stage 3 and 4 are suggestive of NUG and NUP. Are suggestive of NUG and NUP. Okay. Now the next question. Causative organism of ANUG is, it is a fusospirectal bacilli disease, right? It is a fusospirectal disease. Now you can get confused here with Treponema pallidum and spirochetes, but guys remember that Treponema pallidum is also a type of spirochete only. It is a type of spirochete only, right? So the answer to this question is option number A. Now the next question. Which amongst the following are clinical features of acute necrotizing ulcerative gingivitis? This is a multiple choice, means multiple answers are correct here. Options are occurs due to viral infection. No. Bone loss is seen in NUG. Remember, NUG is gingivitis. Bone loss is not seen. Bone loss is seen in what? Bone loss is seen in periodontitis, NUP. Okay. Then punched out crater-like lesions are seen? Yes, this is correct. And recession is seen? Yes. Because of necrosis, what happens is recession. There is no pocket formation in NUG. So the answer here is option number D, which is 3 and 4. Okay. Now the next question. Most common indication of low-level laser therapy, LLT, in peri. This is last year's last year paper in May INI. They have asked this question. Lasers, I would say yes. Last 2 years they are asking, but not that much frequently. But this is a very new topic, and we discuss it in detail, right? Whatever is important for you, we discuss it in our classes. So, guys, yes, laser is one of the recently emerging topics in perio, I would say. And they have started asking questions from that. So, what is low level laser therapy in periodontal treatment used for? What is the indication? Option number A is depigmentation of gingiva. Option number B is bone regeneration. Option number C is wound healing improves. And option number D is periodontal surgeries. So here specifically remember that they are asking for low level laser therapy, and that is specifically used for biomodulation or biostimulation. It is used for improving the healing mechanism of the tissues. So the answer here is wound healing improves. Similarly, I think in 21, this question was asked, INI 21, which of the following laser is used for osseous radicular sections, osseous radicular surgeries? Options are Nd:YAG, option number B is diode, option number C is erbium chromium YSGC, and option number D is carbon dioxide. So, guys, hard tissue laser. Nd:YAG is a laser which is can be used for hard as well as soft tissues, but erbium YAG and erbium chromium YSGC are the lasers which are most commonly used and are more beneficial than the carbon dioxide lasers for the hard tissue laser surgeries. Why? Because in carbon dioxide lasers there are chances of pulpal damage as well, and they're more costly. So mostly nowadays the erbium YAG and erbium chromium YSGC are used for osseous radicular surgeries with lasers. So the answer here is C. Okay, this is something where no application is required. It is something which you need to learn. This is a fact which you need to learn. Otherwise, there is a biomechanic. There is a big biomechanics behind the functioning of every laser, which is at this stage, guys, it is not possible. Afterwards, you can definitely learn it, but now you have to learn, like memorize it. Okay. Next is from the topic of host modulation since last 2 years. Previously, it was not that common, but since last 2 years, host modulation also they have like increased the number of questions from this topic. So, which is not an inflammatory cytokine? Which is not an inflammatory. Piezo surgery is not important, Komal. Till now, from I think one image-based questions, the question was asked from piezo surgery in 2022. That question only they have asked twice, but it is not that very important. But yes, if you have read our question bank, I have given like the all the explanation. In 2023, they have asked, and the explanation is very detailed explanation. If you read that much, also it is more than sufficient. You don't need to remember each and everything. You just need to remember the images of different types of piezoelectric instruments which are used, right? Okay, Komal. Okay, which is not an inflammatory cytokine, which is not an inflammatory cytokine, or which is an anti-inflammatory cytokines. So options are interleukin 1 alpha, option B is interleukin 6, option number C is interleukin 10, and option number D is TNF beta. So just write it down, guys, that what are anti-inflammatory cytokines and what are pro-inflammatory cytokines. Anti-inflammatory cytokines are the cytokines which reduce the inflammation. They are mostly interleukin 4 and interleukin 10. Now, these two are the only anti-inflammatory cytokines. I'm not telling that there are many anti-inflammatory cytokines, guys. But for us, these two are important and you need to remember them. Then there are pro-inflammatory cytokines, the cytokines which increase the inflammation. Write it down. Interleukin 1 alpha, interleukin 6, interferons are there, TNF alpha and beta are there. Then there are CRP. All these are pro-inflammatory cytokines, means they increase the inflammation. So in periodontal disease, when there is loss of balance between the anti-inflammatory and pro-inflammatory, or you could say that when there is increase in the number of pro-inflammatory cytokines, there is periodontitis, the tissue destruction and connective tissue destruction and bone destruction starts. Okay. Now the next question is, which inflammatory markers increases in serum in a person with periodontal disease as compared with a person with periodontal disease as compared to a person without any periodontal disease? Options are option number, obviously, what will increase? Pro-inflammatory cytokines will increase, right? So here the answer will be, B, right? Here the answer will be, here the answer will be B. Okay. Now the next question. From host modulation, or only host modulation therapy is important. So host modulation therapy also, from host modulation therapies, SDD, CMTs are important. You should know the drugs which which prevent bone loss. So not out of the following, which is not used, not is the keyword here, not used in host modulation therapy. Options are option number A, NSAIDs, option number B is bisphosphonates, option number C is amoxicillin, and option number D is periostat. This is an obvious answer, right? Amoxicillin is the answer here. Then SDD dose you should know, CMT dose you should know. SDD ka dose is 40 milligrams, right? Or 20 milligrams twice daily, and CMT ka dose is 10 milligrams once daily. Then local drug delivery, another important topic. Every year one question comes from this topic as well. Here I have just written the question is periochip size and composition. The periochip size is option number A, 4 into 5 into 0.35. This is a simple question, right? But you should know the different types of LDDs which are frequently asked. Acticide contains tetracycline, Atridox contains doxycycline, Aristin contains minocycline, then periochip. Okay, it contains chlorhexidine. Okay, now the next question. Which amongst these is the first clinical sign in traumatic occlusion? First, clinical. The keyword here is clinical sign of traumatic occlusion. Option number A is mobility. Option number B is attrition. Option number C is PDL widening. And option number D is pathologic migration. Some of you might say, ma'am, PDL widening pehle dikhta, right? But guys, here they have specifically mentioned the clinical sign. So look at this keyword here. So here PDL widening will not be the answer. The answer here will be mobility. The answer here will be mobility. Okay. The answer here will be mobility. Yes, it is asking clinical sign, not the first sign. The first clinical sign is mobility, guys, not PDL widening. Okay. Yes, it will be A. Consider the following points. This is means multiple answers are correct here. Option number A is consider the following points. Option number A is marginal gingiva is not affected. Option number B is alveolar crest changes are seen. Option number C is no gingivitis or pocket formation. And option number D is it is reversible. Which of these points are true for trauma from occlusion? So in primary trauma from occlusion, true trauma from occlusion basically is the primary trauma from occlusion. In primary trauma from occlusion, what is there? The gingiva, the gums are healthy, right? The periodontium is healthy, but what is happening? The occlusal forces are increasing. That is primary trauma from occlusion. In secondary trauma from occlusion, what is happening? In secondary trauma from occlusion, the occlusal forces are normal only, guys. But because of bone loss, bone is the base of the tooth. It is supporting the root of the tooth. So, because of the bone loss, what is happening? The load bearing capacity of the tooth is decreasing, right? So, the normal forces are also perceived as heavy forces or traumatic forces by the tooth. That is your secondary trauma from occlusion. So these points, all these points which are mentioned here are true for primary trauma from occlusion. So here the answer will be A, which is primary trauma from occlusion. Okay. The first radiographic sign, Sada, will be PDL widening only. Okay. You want, you can take a screenshot of this table. Then we'll move to the next question. The next question, okay. The next question is, a female patient is taking amlodipine since last 3 years, reported with gingival swelling in OPD. Taking amlodipine, reported with gingival swelling. There is no correlation with plaque and calculus, means the amount of plaque and calculus is not that much that they can cause inflammatory gingival enlargement, right? They have mentioned itself in the question itself, they have mentioned that the amount of plaque and calculus is not that much. So we can rule out inflammatory enlargement from this, right? We can rule out inflammatory enlargement from this option. Which of the following is the cause? This is from the topic subtopic gingival enlargement. Guys, from gingival enlargement, drug-induced gingival enlargement is very important. Pregnancy gingival enlargement is important. These two you should know. Others are, it's okay if you remember or not. But try to remember the classification of gingival enlargement. At least the names of all these gingival enlargements you must know. Okay. So here the answer obviously is drug-induced gingival enlargement. Amlodipine is a and calcium channel blocker, right? Antihypertensive, and it is responsible. Amlodipine and nifedipine are responsible for causing gingival enlargement. Okay, so the answer here is A. Now, question number 14 is Tannerella forsythia. Tannerella forsythia belongs to which group of bacteria? This, so it's like dental plaque and calculus, like it is the bread and butter of periodontics. So one question you will get every alternate year. I will not say every year you will get one question from dental plaque, but yes, every alternate year or in every alternate paper or either in INI or NEET, you will get one question from dental plaque. Specifically, complexes of bacteria are very important for peri. So these complexes we have discussed very nicely, and you should remember it nicely. In our live sessions also, in our recorded sessions also, we have discussed it nicely. So try to remember it in that way. Okay. So, Cannella forsythia belongs to which group of bacteria? For this, you must know this complex diagram which was given by Sobransky. I'm not going into the detail of this, like what these complexes are trying to say. By now, you must be very thorough with this. So this is like taught very nicely in the classes, live sessions as well. Okay, so Tannarella forsythia belongs to red complex. The bacteria which are there in the red complex are gram-negative anaerobic. They are obligate anaerobic bacteria. So the answer to this question is option number A, gram-negative, obligate anaerobic bacteria. Okay, it is A. Similarly, they can ask match the column type of questions. Now, guys, I have taken this specific question, basically to tell you guys that don't try to match everything in this, right? You have a very limited time. So, what you need to do, you know that P. gingivalis belongs to red complex. So, what you can do is just go to the options and see where A and 2 are together. So, here in option number C, you can say that A is A and 2 are together in C. Everywhere else it is not there, right? So option number C is correct. Don't try to correlate everything and then see it. Okay. Try to save your time as much as possible. Then this last question of today's discussion, maximum amount of crystals in calculus. From dental calculus, specifically, you need to be very thorough with the composition of calculus, both the composition of supragingival, the crystalline structures which are present, hydroxyapatite, brushite, magnesium, white locite, and octacalcium phosphate. All those four are the major crystals which are present in dental calculus. And you should be thorough that which crystalline structure is predominant in supragingival and in subgingival calculus. In supragingival calculus and subgingival calculus, hydroxyapatite is predominant. Okay. After hydroxyapatite, in subgingival calculus, magnesium white locite is very predominant. Okay, so you must be thorough with the composition of dental calculus. Other things are not that important in dental calculus, but yes, composition is very, very important, guys. Okay, now maximum amount of crystals in dental calculus? Yes, the answer here is C. Okay, now I'll just quickly take doubt, Sada's doubt, and we'll wrap up the session. Sixth, crown lengthening question it was, right? Yeah, this one. Okay. So in the question, what they are asking, what they are telling, that a crown lengthening procedure is to be done on a premolar. The height of that premolar. Imagine if this is the tooth, okay? If this is the tooth, this is the gingiva, okay? This is the gingiva, or I would say, let us take a normal tooth. This is a tooth. This is the level of gingiva. The tooth is broken from here. The tooth is broken at this level. So it is at the level of the gingiva, equigingival. Okay. Now again I will draw this tooth. Now here what they are saying is there is 3 mm of attached gingiva and 2 mm of transgingival probing. Transgingival probing. What is transgingival probing? If this is the bone, right? If this is the bone, I'll take the probe, I'll give infiltration, local anesthesia here, and lump this area, take my periodontal probe and take it up till the alveolar crest. I'll penetrate the probe up till the alveolar crest. This transgingival probing depth is 2 mm. This transgingival probing depth is 2 mm. Right? Means total of this up till here. This Up till here, it is 2 mm. Understood, Sada? This much, is it clear? What is transgingival probing? I hope you know that. This is 2 mm. Okay. Now, we know that biologic width, there is a concept of biologic width, which is the width of the connective tissue from the junctional epithelium up till the alveolar crest. This much should be at least 2 mm. This much should be at least 2 mm. If this 2 mm is not maintained, what will happen? There will be more bone loss, there will be plaque accumulation, there will be more connective tissue loss, right? If I have to do crown lengthening, if I have to do crown lengthening, I need minimum. To retain a crown, minimum amount of tooth which I require above the gingiva. Above the gingiva, the height of the crown which I require is approximately 2 mm, right? I have to place the crown here. If that much height is not there, what I'll do? Either I can do gingivectomy, just gingivectomy. When I will do gingivectomy? When there is sufficient amount of tissue present. If more than 3, like if the more than 4 mm of gingival tissue is above here, like, understood? If this is the tooth, this much, and this is the bone. Okay, this is the bone. Here, 2 mm height is present. This total length of gingiva is, suppose it is 5 mm. What I'll do? I'll just what I'll do? 5 mm, and I need 2 to 3 mm is sufficient, right? I need 2 to 3 mm. I will just cut 3 mm of the tissue from here with the help of gingivectomy. I'll cut this much of the tissue, and this much crown will be exposed, right? 3 mm crown will be exposed. I can easily place the cap here. But here, they are saying that it is at the equigingival level. The total length, the total transgingival probing from the gingival margin up till here is 2 mm. I need minimum 2 mm of crown, means I need the crown exposed till here, right? I need the crown exposed till here, and after that I need 2 mm of biologic width, means 2 mm of the connective tissue here. So the bone level should be 2 mm below this height. It should be below 2 mm below this height. What I'll do? I have to reduce the bone. I have to reduce the bone. So osseous reduction needs to be done. Okay. But as the gingival tissue here is very less, it is not even 1 mm, right? The total transgingival probing depth is 2 mm. So suppose it is just 1 mm, just by cutting the gingiva will not help. What I need to do? I have to take whole of this complex downwards. Shift the complex downwards means apically. I have to shift it apically so that, and when can I shift it apically? When the bone is reduced, right? When the bone is reduced from here, first I need to reduce the bone. I need to gain that space to take the tissue downwards. So I'll cut the bone from there. I'll do osseous resective surgery, and then I'll take the tissue down, the gingiva down with the help of apically repositioned flap. Then I'll get 2 mm, minimum 2 mm of crown height here. Understood, Sada? Now is it clear? This is a little bit complex thing, but if you what I have told you, and once again you will go through the notes, you will understand what I am trying to tell you. Understood? So guys, it is 9:12. Okay. Okay. So thank you so much, guys, and just stay focused, keep working hard, and all the best for your exam.